Good morning. This is the last part in common pediatric illnesses today that we're going to be focusing on. So we will have the common pediatric infections today. We'll be talking about acute otitis media, which is one of the most common reasons for antimicrobial use in children, in fact. And acute otitis media, or AOM, is most common in ages of 3 months to 3 years. And the highest incidence normally occurs between 6 and 9 months of age. Incidence is higher in winter months, as you know, and concurrent with viral upper respiratory illnesses. Most of the times it comes after a viral infection. Several risk factors might lead to or predispose the child to have acute otitis media. If they have if they are less than 2 years of age, early colonization of pathogens and onset of AOM, daycare attendance, for example, children who attend a daycare, they are more prone to have otitis media. Bottle probing, cleft palate, this is a condition they are born with. Immune compromise, they have reduced immunity, and Down syndrome. Some other factors, they have not been consistently found to increase the risk. So they are a kind of contradiction in terms of the studies. Some of them they support, some of them they refute the hypothesis of being or causing or leading to higher risk of acute otitis media, like smoke exposure. And if they are exposed for smoke, for example, they are having higher risk, but this is kind of controversial. Bottle feeding and pacifier use and ethnicity. More certain ethnic groups, they are more prone than other ethnic groups to have more otitis media. So the primary condition required for the development of acute otitis media is Eustachian tube dysfunction. That's what's happening in children. From two things: intermittent causes, such as upper respiratory tract infection, or permanent causes, such as a cleft palate. Because of that, Eustachian tube is really short. Sometimes it might happen they have more recurrent otitis media infection than other normal children. This results in a defect in the Eustachian tube's ability to equilibrate the middle ear pressure. Then the pressure is different now, it's not in equilibrium. Thus, nasopharyngeal contents, including bacteria, of course, it's colonized with a lot of bacteria, may be aspirated into the middle ear. And that's what's happening. So if you get this nasopharyngeal contents get aspirated into the middle ear, including bacteria, will lead to infection in the middle ear, which is called acute otitis media. This process is more likely in infants and young children who have shorter, flatter Eustachian tube. And the change in pressure can also cause increased vascular permeability, which leads to further effusion, of course. Further effusion happening in those patients. And if you want to contribute it to more viral infection, contribute by enhancing bacterial transfer from nasopharynx and adherence to the middle ear. So this complex of factors, as you see the pathology, so we have multiple factors might be involved, but the common thing is the transfer of these fluids or contents of nasopharynx into the middle ear and causing the infection. The most common pathogens causing acute otitis media, the S. pneumonia and non-typical Haemophilus influenza and Moraxella catarrhalis, they colonize the nasopharynx early in childhood. So they are there, When they get the chance, they will transfer into the middle ear and causing that infection. Therefore, they try to introduce a vaccine for that, the introduction pneumococcal conjugate vaccine, or the PCV7, reduced the overall incidence of otitis media. They reduced the recurrence of otitis media and the need for tympanostomy tube insertion, which is a kind of a surgical intervention trying to relieve the problem. So therefore, that injection or that vaccine helped to reduce these symptoms. However, the incidence of otitis media caused by non-PCV7 serotypes of bacteria, like Haemophilus influenza, Moraxilla catarrhalis, increased with the reduction in otitis media cases reduced or caused by PCV7 serotypes. Therefore, they introduced another vaccine, the 13-valent PCV or PCV13, was approved and licensed to replace the older version, which is the PCV7 in 2010. With the introduction of this PCV13 vaccine, it included 6 now of the serotypes that had been shown to produce more than 60% of non-PCV7 vaccine strains invasive infection. So they have a broader spectrum. They're covering a wider range of bacteria, and they have shown increased protective effect against otitis media because of the reduction in nasopharyngeal colonization by emerged serotypes of these bacteria. Overall, studies have shown that PCV13 provides a reduction in pneumococcal disease, including otitis media or acute otitis media in children. Very often, otitis media is preceded by an upper respiratory tract infection. We're talking about viral infection in particular here. Often will produce that otitis media with effusion. There is a fluid, liquid is coming out of the ear, what we call it OME, otitis media with effusion, which typically will cause no more than temporary mild hearing loss. So if you hear the child, sometimes they will have temporary or mild hearing loss. It's painful. Therefore, if you touch their ear, sometimes they are crying for no reason. They don't show anything. But if you, by accident, touch their ear, it's going to be painful. Then you will think about something happening in the ear. Kinds of symptoms of AOM, otalgia, which is pain causing infants to pull on or rub their ears. If they are touching their ear, trying to rub their ear because of the pain in that ear. So you think about otitis media. They have fever, which is an indicative of bacterial infection. They have irritability. They are nervous, they are not happy, they are not relaxed. And otorrhea. Otorrhea is the fluid oozing or coming out of the ear. Unfortunately, aside from that otorrhea, these symptoms, they are not specific. They are not differential or help us to make a differential diagnosis for otitis media. So maybe present in many children who don't even have otitis media. As a result, if you need to do a differential diagnosis, it may not be easy to do so with the symptoms alone. So if somebody has to go and look inside the ear, and that's why diagnosis should be confirmed by visualization of the middle ear. There are certain guidelines from the American Academy of Pediatrics to diagnose otitis media. It requires mild bulging of the tympanic membrane, and this needs experienced ENT specialist or a clinician who is specialized or have more experience with that. They can tell you there is mild bulging, for example, in the tympanic membrane, and either recent onset of ear pain, more than 48 hours, or intense erythema of the tympanic membrane. If you look at it, you will see it's kind of inflamed, red. And number two, pneumatic otoscopy. Otoscopy is something you look inside the ear. That's the device. Normally, the physician look at the ear to confirm the presence of effusion. Number three, the middle ear effusion can be differentiated from acute otitis media, whereas both with bulging tympanic membrane. The middle ear fluid is more often dark yellow or red. So again, we need to differentiate whether this is in the inner ear or the middle ear effusion. We have to look at the color of that fluid coming out. And other diagnostic methods, of course, they will be utilized by physicians. Tympanometry used sound waves to measure the compliance of the tympanic membrane. And in acoustic reflectometry, the absorption of sound waves, also that might be one of the methods they can rely to diagnose that. In 2013, the American Academy of Pediatrics, they recommended, or their recommendation provided an option to observe without a treatment. So before you initiate a treatment, you have to look at the disease, symptoms, severity, the whole picture. Before you start a treatment, you have to look at certain things. Do I need to treat? That's the first question. If you have a case coming to your pharmacy and you think this is an otitis media, so you have a decision now. You are at the road cross. You either go right or left. So should I treat or should I not treat or just observe? There are certain guidelines for that. Observe without a treatment or to treat with antibiotics depends on two things: the age of the child and the symptoms are present. Generally, if the child age or the infant is 6 months or younger, should receive antibiotic therapy in all cases. So that's a critical point, a critical age. If the age is 6 months, then definitely you need to treat and give antibiotics. If the age is between 6 months and 2 years, this can be managed with observation if there is a non-severe unilateral acute otitis media without otorrhea. So if the ear is it's only pain in one ear with no otorrhea, no fluid coming out of that, you just observe, provided between 6 and 2 months, say 6 months and 2 years. Children 2 years of age and older can also be managed by observation in bilateral or unilateral, non-severe. Again, severity, look at the severity, the number of ears involved is unilateral or bilateral, and the age. So we have 3 factors now: severity of symptoms, the ears involved, and age of the child. Antibiotics, they are needed or they are mandated, they are warranted in all cases of acute otitis media with otorrhea. Whenever you have otorrhea, then it's a mandate to have antibiotics, or in acute otitis media cases with severe symptoms. How do we know this is severe? Body temperature. When the temperature is more than 39 degrees Celsius in the past 48 hours. So this way you will see there is a need for that. Despite pneumococcal penicillin resistance rates, so these causative agents, these bacteria, the pneumococcal bacteria, normally have penicillin resistance. Initial therapy in most children who have not received amoxicillin in the last 30 days still should be amoxicillin with a dose 80 to 90 milligram per kg per day. So provided that they have not received amoxicillin, so you should not give amoxicillin like twice a month. Amoxicillin is still effective against susceptible and intermediately resistant pneumococcus. It is affordable. These are the advantages of amoxicillin in this disease, and palatable. It's not a bad taste. and it has a narrow spectrum of activity. I'm not talking about the gram-positive negative here, but generally on the number of bacteria, it's kind of some specificity or narrow spectrum against these conditions or bacterial or causative agents. Providers should prescribe the combination augmentin or amoxicillin plus clavulanic acid in children, provided that they have three conditions here, one of the three conditions, who have received amoxicillin alone in the past 30 days. So if they have received amoxicillin, look at the previous month, don't repeat amoxicillin within a month. Give the combination now, amoxicillin plus clavulanic acid. Because the reason for that, the first time you gave amoxicillin, then the child came back within a month with another infection, which means amoxicillin alone was not really effective. So you need that combination with the clavulanic acid. Number two, who have concurrent purulent conjunctivitis. Purulent, which is kind of secretions or pus coming out of the conjunctiva of the eye, or have a history of recurrent acute otitis media unresponsive to amoxicillin. All the time you give amoxicillin, then the infection coming back again, which means amoxicillin alone is not effective. Then you have to give the combination of, but don't start the combination from the beginning. Always start with monotherapy, this way to keep resistance to the minimum. Now, other antibiotics like oral cephalosporins, including cefdinir, cefuroxime, cefuroxime, these are options in patients with a non-type 1 allergy to penicillin. As you know, there is a cross-reaction or cross-sensitivity between penicillins and cephalosporins. But if they have non-type 1 allergy to penicillins, then you can give cephalosporins. Macrolides such as azithromycin, Zithromax, or clarithromycin classide may be also used in those with type 1 allergies to penicillins. So if they have type 1, then definitely don't give penicillins or cephalosporins. Then you have to stick to the other group, the macrolides such as azithromycin or clarithromycin. Then you need to follow up. Let's say the prescription came to you today, then follow up with the patient 2 days and 3 days afterwards. So ask the patient to call you after 2 days, what's happening? Did the symptoms subside? Did the patient improve? If the treatment is effective, the patient should diverfees, which means the body temperature should go down. Ask them when you follow up with a follow-up call, did the temperature go back to normal? It went down from 39 to normal body temperature. Irritability should also decrease. Is the patient still nervous? The child is still nervous or irritable? Especially in very young children, they keep crying. Did that crying stop? Normal activity should resume. For example, eating, sleeping, playing, jumping, etc. So when the child is sick, you will see that they are all the time they don't have normal activity. So ask them, did they go back again and they're eating normally, they're sleeping normally, they're playing, etc. They're smiling, they're laughing, they're, these things. So if the observation is ineffective, then treatment with amoxicillin or amoxicillin clavulanic is recommended. So you came across one of the cases, and according to the age and symptoms, as we said, you did not recommend giving antibiotics. You just observe, but after observation, you still have the symptoms, the pain, like it's not self-limited at this stage. Then you need to initiate the treatment, and the initiation of a treatment should be with amoxicillin. And again, according to the guidelines we mentioned, you might also use after that amoxicillin with a clavulanate. So amoxicillin or a clavulanate or amoxicillin with a clavulanate is ineffective. You will jump one step and give ceftriaxone IM 400 milligrams or 50 milligram per kg IM for 1 to 3 days as an alternative or as an option. Now, the other part of the management, only antibiotics, but as we said, we have otalgia, which means pain in the ear. It's a very common feature also in acute otitis media. It should be addressed regardless of the decision to treat with antibiotic or not. This is independent of a treatment of antibiotics. So we said the treatment or observation, but when they have pain, you need to treat that pain. Normally, the first line agents used to treat pain, they are acetaminophen or ibuprofen. So you give 100 milligram or 50 milligram per kg, or ibuprofen 10 milligram per kg can provide adequate relief, and they are considered as first line in the management of otalgia. Other measures that you could take also at home, the home remedies or methods that they can relieve pain by the application of heat or cold may also be helpful. For example, a cloth can be soaked with very warm water, wrung out, put it on the top of the ear and roll it for comfort like every 15 minutes, several times per day. It should also relieve pain if you don't want to use medication or in combination with acetaminophen or ibuprofen. The next disease also among the common pediatric infections is acute pharyngitis. It's pretty common, what we call it sore throat or strep or etc. This is acute pharyngitis is also the most common, but it's in a different age group from 5 to 15 years of age. And it's rarely before 3 years of age in children. The etiology, typically viral, but there is also bacterial sometimes. Sometimes they get, after each other. For example, if they start with viral, then you will have bacterial. Since immunity went down, then bacteria will get in. And that's why sometimes when you go to the pharmacy, you see there is a viral infection, but they're still giving antibiotics. It depends on the patient history. If in the past experience, whenever they have similar symptoms due to viral infection followed by bacterial infection, then I think it makes sense to give antibiotic from the beginning so you avoid bacterial infection. The most common causative agents in this condition for acute pharyngitis are group A streptococci or GAS, GAS, group A streptococci, like Streptococcus pyogenes, group C and G streptococci, Neisseria gonorrhea, Mycoplasma pneumonia, and Chlamydia pneumonia. So as you see, different agents from bacterial family, they might cause this acute pharyngitis. And the majority of attention is directed toward the detection and management of the gas infection, the group A streptococci infection. As untreated, if you leave them untreated for a certain period of time, why do we need to treat now with antibiotics? Because of the risk of having rheumatic fever. And as a complication for that, the child might progress into a permanent heart disease. It will attack the valves of the heart. That's the problem. So that's why we need to correctly diagnose the condition, and you need to diagnose and collect information. What findings they suggest that there is a GAS transylopharyngitis. Some of the symptoms that they have, normally sudden onset of throat pain. All of a sudden they will start having the throat pain. They have fever. They're common conditions, the common silent symptoms, of course, like headache, abdominal pain, nausea, vomiting, tonsillopharyngeal edema, enlarged anterior cervical lymph nodes. They will touch them and feel them. You'll see that like they are enlarged more than normal. Soft palate petechia. So the soft palate, you will see like it's kind of inflamed, enlarged, and red in color. And scarlet uniform rash. Sometimes they will appear like some rash. The symptoms that increase the likelihood of viral, on the other hand. The upper one's suggestive of bacterial infection, but if you look at the viral type of this infection, they might include rhinorrhea, saline fil-anf, cough, conjunctivitis, and viral rash. So again, the differential diagnosis needs sometimes medical expert to diagnose, but it's good to know what the methods. In order to be sure what exactly the causative agent, then rapid antigen detection test. So bacteria will produce an antigen. So this way, if positive, a treatment is initiated. You have antigenic effects, then you will have to introduce antibiotic in this case. If negative, take a confirmatory test by taking a throat culture and look at the results of the culture. So treatment initiated, if the culture grows, then you have the GAS or gas or group A streptococci. The risk always is we are afraid of rheumatic fever. It can be effectively prevented if a treatment is started within 9 days from the start of the illness. So if the illness, you can still wait a few days, but you don't have to. But again, in order to prevent the development of rheumatic fever, you could still prevent that if you started or initiated a treatment with antibiotic within 9 days from the start of the illness. The treatment for acute pharyngitis is still penicillins remain the agents of choice for group A pharyngitis or Streptococcus pharyngitis. Oral penicillins, you have powder, you just reconstitute it, or tablets, or oral amoxicillin, or even for severe cases, or if they could not take it, then you have the option of intramuscular benzathine penicillin. Very quick, very rapid action. They will improve very quickly. The advantage of amoxicillin now is amoxicillin suspension. The taste of amoxicillin suspension is better than penicillins and has the advantage of a once daily dosing regimen sometimes, especially if you have the higher dose. The IM, intramuscular penicillin, is a one-time dose that can be helpful in those at risk of non-adherence. So if you feel that the patient is not going to stick to their oral medication, then the option is to give them intramuscular penicillin injections. Now, what if they have hypersensitivity? If they have type 1 hypersensitivity to penicillin, then you can't give even the second, which is the cephalosporins. Then the option is to give the macrolide like azithromycin, clarithromycin, or even clindamycin may be used. In those with non-type 1, you could use now first-generation cephalosporins like cephalexin may be considered as an option for those patients. Although there is a little reported group A Streptococcus resistance to penicillin, some patients have a decreased clinical response and may respond better to cephalosporins. So it depends again. With experience, you will gain that experience. So this is often seen in patients who are GAS carriers and those who may have the bacteria causing infection. So patients are no longer contagious. ما بيعدوا other people after the first antibiotic use. So once you start the antibiotic, it's not contagious because you are limiting bacteria in this case. This table will show you the medication regimens that normally they are used for the treatment of streptococcal pharyngitis and the prevention of rheumatic fever. The first group of these medications are the penicillins, including amoxicillin, penicillin K, and benzathine penicillin. As you see, it's an IM. So these are the dosage regimen with the duration. It's about 10 days for amoxicillin, you give it, and penicillin for 10 days, but the intramuscular injection for only one injection. Sometimes you follow up with oral after that. Now assume the patient, they have penicillin allergy. And again, if it's non-type 1, then you can give cefalixin, cefadroxil. If it's a type 1 sensitivity or allergy, then you have the option of clindamycin, azithromycin, clarithromycin. The shortest action or course is for azithromycin, sorry, Zithromax. So it's only for 5 days. Normally start with the double dose initially, then you follow up with the regular dose on daily basis. The patients who have also history of rheumatic fever, they already started the development of rheumatic fever. It's characterized, we need to remember لؤي, we need to remember يعني احنا بالعاده الدوسز طبعا نحفظها الدوس للانتيبيوتكس، يعني مش صعبين انه نحفظهم على الدوسز في الانتيبيوتكس لانهم very frequently used. يعني most of the medications that you normally use or dispense at the pharmacy, yes. So acute generalized inflammation of the heart. ايش اللي بيحصل? What's happening with rheumatoid fever? So you will have antibodies. They will attack the heart, especially the valve, the joints, the brain, skin. They normally, this patient population, we should treat them carefully. They should receive a long-term antibiotic prophylaxis. It's not only 10 days. Why do we need to follow that regimen? In order to prevent further complications from coccal infections. And the recommendation, as we will see in the table, and dosing regimen are summarized in the next slide in this table. I'll show it in a minute. So patients with acute carditis and residual heart disease, they should receive a treatment for 10 years. So you see, this is really a very, very long period of a treatment until 40 years of age. يعني لما يكون طفل لما يصير تقريبا 40 سنة whichever is longer. يعني افترض كان 30 حتى ب 10 سنوات تكون 40، بس لو كان عمره مثلا 15 سنة 15 حتى يصير 40 ونعطيه 25 سنة treatment with antibiotic. Otherwise, you will hit or you will attack the heart. So patients with an episode of carditis, but without residual heart disease, they should receive a treatment for 10 years or at least until 21 years of age. يعني غالبا بلش بالطفولة، فكمان بده يستلم antibiotic treatment لمدة 10 years أو حتى لما يصير عمره 21 سنة. وأجين نتبع دائما الفترة الأطول. Patients who had rheumatic fever without involvement of the heart, without carditis, they should receive the treatment for 5 years. It's shorter, a little bit shorter, or at least until 21 years of age as well. So this is the dosage regimen or the medication regimens that we use in the prevention of recurrent traumatic fever. فالبيشنت اللي بيصير pharyngitis أو التهاب اللوز اللي عنده بيؤدي إلى fever, so they have to use frequent medications. And as we said, for 10 years, for example, benzathine penicillin. Normally بيعطوهم إبرة شهرية. Every 4 weeks they will have to take حسب البودي weight. فبنعطيها مثلا 600,000 units intramuscular واكثر من 27 كيلو جرام راح يكون تقريبا ضعف هذه الدوز 1200. البنسلين V 25 milligram oral. I think people they might like the intramuscular more than the oral because of compliance issue. We're talking about 10 years of a treatment. Every day they have to go and take 3 or 4 times penicillin, for example. But every month they will go to the clinic or the clinic. Normally they will take that intramuscular injection, more convenient. Sulfadiazine once daily, or if they have allergy to the above medications, they have the option of erythromycin. Erythromycin 250 mg orally twice a day should resolve the problem. So with that بنكون كملنا chapter